This is the Psychology of Seattle, Psychology in Seattle podcast. I'm your host, Dr. Kirk Honda. I am chair of the Couple and Family Therapy program at Antioch, Seattle, and I'm also a licensed psychotherapist. Okay, so I thought I would read a question or just a comment from a supervisee of mine. She said, this was a while back. I have a worksheet that they fill out. And so here we go. The supervisee, who I will remain anonymous for her sake, she says that she had a family session and she was talking about, let's see, scanning, I'll summarize. Okay, so basically what happened was, on this worksheet, I asked people to discuss a moment of countertransference that they had recently. And she said that she had a family session and the family started talking about the parents fighting, meaning the parents, the mother and the father were in conflict. They were talking about a story. So the family's in session, and one of the children is like, yeah, my mom and my dad were fighting, and it was really horrible, da-da-da. And because of the history of this therapist, this triggered countertransference in her, and it caused her brain to freeze up, she said. And then she was unable to really address anything new in that session because she had been triggered, and she had to contemplate it, get supervision, get consultation, and then come back to the issues in the next session. So this is a very wise thing for this therapist to write and to notice about herself. We all have our issues in our past, and they will undoubtedly get triggered many times by our clients because so much of our lives overlap with our clients' lives. And so she's wise to have noticed this. Often with novice therapists, and I would say even with experienced therapists, when this happens, there's a lot of shame as a therapist. You think, well, I should be able to handle it. What's wrong with me? I should be over this. The fact of the matter is none of us are over our issues, and all of us will be triggered from time to time regarding our countertransference. And we will all have difficulty noticing it at the time. We'll all have difficulty managing it at the time. And we're going to make mistakes, and that's natural. We're not gods. We're not superhuman. We are human beings, and we have emotions, and we have issues. And sometimes treatment will suffer, as it sort of did. She's not saying that directly, but she's saying that her brain froze, and I'm imagining that your quality as a therapist is going to dip if your brain is frozen. But that's okay. That's completely normal, and it's fine. And so I commend her for saying that. Okay, so I have another question here from a supervisee saying, and actually this is just a preamble to the question that she asked that I'm going to address. She says that she had her first client that she did not diagnose with GAD, or generalized anxiety disorder. If you're not in the business, you probably don't know this, and if you are, then you might know this. But how do I explain this in a short way? Basically, in order for health insurance to pay for services, and basically in order for clients to be able to afford services since they're expensive, there has to be what they call a medically necessary diagnosis. When you go to your doctor and your physician, and they provide a treatment, there has to be a diagnosis to justify the treatment. The physician can't just administer a treatment to you without some form of diagnosis. Well, it's the same when it comes to mental health and behavioral health issues. There has to be a diagnosis. There has to be a justification for the insurance or for the government in terms of Medicaid to pay for treatment. And so you need a diagnosis. There needs to be a reason, and it needs to be necessary. And so in the DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, there are a wide swath, hundreds of diagnoses that we as clinicians and intake people and assessors can choose from to justify treatment. And the thing is that there are certain disorders that over time clinicians tend to gravitate toward because they are easily endorsed. They are easily applied to many, many clients. So obviously, if someone comes in with full-blown schizophrenia or full-blown bipolar or full-blown major depressive disorder, then it's not hard to diagnose them, it's not hard to detect them, and it's not hard to justify treatment. However, often there's a wide, I don't even know the stats. From my personal experience, it's in my field, it's probably like 95% of clients do not fit very succinctly or easily or obviously into a diagnostic category. And they come in and they're kind of depressed, they're kind of anxious, they're kind of stressed. They have a lot of issues going on in their life, in their family, at school, in their relationships, in their parenting, and with money, at their job, and at their health. And it's hard to figure out what diagnosis to apply to them. They don't fit criteria for any of the classic disorders like major depression or any of the psychotic disorders or anything along those lines. And so it's hard to fit them into a category. But unless you as a clinician diagnose them, then you can't help them, even though they are desperate for your help. And so what happens is you'll have clinicians searching for a diagnosis that fits their client. And what a lot of, when I was younger in the 90s, the diagnosis that people would go to was what they called adjustment disorders. And these are a somewhat unknown diagnostic category that applies to a lot of people. It applies to a lot of people coming into therapy. The summary I could say is you have someone, they don't have any symptoms, and then they experience some sort of stressor, like they move, or they lose a job, or they have a health problem, or a breakup in their relationship or something, some kind of stress in their life, some kind of event that's stressful to them. And then after that, they have symptoms. They have anxiety symptoms or depression symptoms or conduct issues. But these issues are subclinical in that they don't meet the criteria for depression or an anxiety disorder or some other issue. So they have a stress and then the stressor, and then they have mild symptoms afterwards. And this is what they call an adjustment disorder. And that's a very brief, in a nutshell, summary of the diagnosis. So you can imagine that a lot of people would fit those criteria. And so when I was an intern and starting out as a therapist, I looked around me, and a lot of the clinicians around me were applying adjustment disorders to a lot of their clients. Well, over the years, I think what happened was Medicaid, so this is a lot of just me basing this on my own experience. I'm not exactly sure if this is correct, but I do know this, is that eventually Medicaid, the government medical insurance, decided to excise adjustment disorders from their list of acceptable diagnoses that they would pay for. And so in order for people and agencies to get their clients treatment, they could no longer diagnose them with adjustment disorders because it was one of the diagnoses in the DSM that Medicaid did not pay for. Other insurance companies would pay for it, like private insurance, like Blue Cross, Blue Shield, these people, but not the government insurance. And the agencies primarily serve people that are using government insurance and mental health insurance. So all these clinicians at these agencies had to switch to a different catch-all diagnosis, and what they landed on was generalized anxiety disorder. And what I started hearing from my supervisees is, I even had one supervisee once say to me, "Well, I can always diagnose them with generalized anxiety disorder, or GAD. It's such a frequently used diagnosis in my world that they just say GAD or GAD." And so I was talking with her, and she said, well, I can always apply GAD. And I said, whoa, what do you mean you can always apply GAD? Because it's illegal and it's unethical to diagnose someone with an illegitimate diagnosis. It's fraud, it's stealing, it's lying, it's no good, people. And you can get in trouble for it, and you should get in trouble for it. So just to say that you can apply GAD to anybody is unethical, bad practice, and lying. And what I tell people is, find a legitimate diagnosis by all means, because we want to be able to help people. But if someone doesn't qualify for a legitimate diagnosis, then you can't diagnose them. And there are other avenues for people to get help. If they don't have a diagnosis, then to some extent, by definition, they don't really need your help that badly. And they could find help from, say, a non-clinician. So say, for instance, someone comes in and they're stressed out about their life, but they're not extremely stressed out, and they don't fit any diagnosis. Well, they could benefit from therapy, but they could also benefit by talking to their minister, talking to their teacher, talking to their mentor, talking to a friend, or talking to other people, or doing some self-help. There's a lot of avenues to getting help that don't involve utilizing the mental health system, which is quite expensive. Now, having said that, if I had it my way, everyone could have free therapy all the time, because I think therapy is a wonderful thing and helps a lot of people that have diagnoses and a lot of people that don't have diagnoses. For instance, myself, I've sought therapy before and have not met any criteria, and therefore pay out of pocket. Now, I can afford that, so that's something to think about. But anyway, so this supervisee is writing, I have my first client that I did not diagnose with generalized anxiety disorder. And it's just like, what? Your first client? Like, according to statistics, really, you shouldn't be diagnosing many of your clients with GAD. There should be a small percentage of people that qualify for the diagnosis, because it's a very specific diagnosis. That's the other thing. I think there's this massive misunderstanding of what generalized anxiety disorder is, because generalized anxiety disorder isn't actually that common. For instance, according to statistics, the 12-month prevalence of generalized anxiety disorder is 0.9% among adolescents and 2.9% among adults in the general community. So in other words, somewhere between 1% and 3% of people in the United States at any given time have generalized anxiety disorder. So it's fairly rare. It's on the level of like schizophrenia or something. It's a fairly rare disorder, because it's quite specific. There are several other anxiety disorders. There's specific phobias. There's OCD, and there's agoraphobia. Social anxiety. There's a lot of different anxiety disorders. So generalized anxiety disorder is just one of those disorders. And again, it's quite specific in its presentation, and to think that it could apply to just anybody is irresponsible and silly. And I think part of the problem is that the description in the DSM of GAD is so broad that it could easily be applied to a lot of people if you don't understand what the disorder is. So, for instance, some of the symptoms are restlessness. So how many people feel restless? Restlessness is a common thing. If you ask someone, do you feel restless? A lot of people say, yeah, I guess I do. Being easily fatigued, being easily tired. I mean, again, ask Americans, do you feel tired right now? The vast majority say yes, but that's not because of generalized anxiety disorder. It's because of a lot of other issues. Another symptom here, difficulty concentrating. How many people have difficulty concentrating? We're talking a lot of people. Okay, irritability. How many irritable people are there around? There's a lot of irritable people. Muscle tension. Again, lots of reasons you could, have regarding muscle tension. And then sleep disturbance. Again, most Americans are suffering from sleep deprivation and therefore have sleep disturbances often. So these criteria are so broad and really off the mark in my mind. Now, a main criteria is the individual finds it difficult to control how much they worry, and they worry a lot. But again, if you ask the average American, do you worry about things? Most people are going to say, yeah, I do worry about things. But the difference is that if you understand generalized anxiety disorder, if you understand the difference between excessive worry and regular worry, you'd be able to assess that in your clients and therefore eliminate a lot of clients from qualifying for generalized anxiety disorder. Because generalized anxiety disorder is extreme. Yes, you worry often, and most of us worry often. But generalized anxiety disordered people, their worry is pretty much constant, and it's extreme, and it interferes with a lot of things. It's not just like, oh, I've been worried about this deadline, or, oh, I've been worried about my marriage. No, they worry about everything. They worry about death. They worry about their family. They worry about money. They worry about their job. They worry about their, the weather. They worry about their place burning down. They worry about whether or not they're going to make it home on time. And it's extreme worry. If you heard someone with generalized anxiety disorder talk about their worries, you would say, holy crap, you have a disorder. You would say, that sounds extreme. There's something very different about your worry as opposed to my worry, which is non-generalized anxiety disorder kind of worry. Okay, people, if you're still listening, please become a patron of the podcast by going to patreon.com so we can start paying our co-hosts because they deserve it. And you should take care of yourself also because you deserve it.